Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Mount Sinai Hospital Cardiac Catheterization Laboratory in New York City. My name is Pedro Moreno. I'll be your moderator today. And please send us all your questions. We really love to hear from you. You can do it through the website or through YouTube. Remember, all our Structural Heart Life Cases are available in ccclifecases.org. And now let me transfer you to our heart team in the cath lab that is going to present the case.
All right. Good morning, Pedro, and welcome to our Structural Heart Live viewers. We are showing a very interesting case, and that actually delayed this, and you'll see the logic behind that why we are a little delayed, because it's a very unique, first of its kind, the 51st case of the structural heart with the team here, which will include myself, Dr. Keeney behind me, and actually surgeon. We are missing Gilbert Tang, so we have surgeon Dr. Farjan Filsufi, and then there is another part here. We have another surgeon because there is a vascular issue, and that Remy Tadros right here, and then Shail Khera, our structural director, and the fellows, and many other team members here, along with on the echo Dr. Lerakas and anesthesia Dr. Moi Trin. So all are here to showcase a very unusual patient in case where two real multidisciplinary, where not only the structural but also the vascular case will be done. With that note, we can start presentation of our case. Let's start the slide, please. These are our supporters, and this is all team members as shown above, I have spoken about, and this patient will be the TAVR for severe AS with combined EVAR for AAA. So this has been, we have done few cases. How many we have done so far? This is 12
abdominals and maybe 5 thoracic.
Yeah. So quite a bit have been done. We thought it will be a good showcase, this 51 episode of Structural Heart Live, 79-year-old patient with worsening dyspnea, and of course, patient has multiple PCIs before and CKD, severe AS, and then was found incidental 6.4 centimeter fusiform dilatation of the infra-renal aorta. So I'll come back and we'll ask our surgical colleague, Dr. Ardos, a little more once we show those pictures. Good medical therapy. Patient did have a PCI recently, and otherwise severe AS, and we'll show the echo and good ejection fraction in this particular case. So now this is the old, our earlier, and now we'll show the live. If we can go to with a tri-leaflet, severe aortic stenosis with calcification. So can we show the live echo?
No, they can't. It is.
No, they will do. They'll do. Yeah, right there.
Yeah, yes,
okay.
Yes,
now, Stam, you say it loudly. What's going on?
Yes. Good morning. As you can see, normal RV function, no pericardial effusion, thickened and calcified aortic valve leaflets with decreased excursion. The patient does have very good images, but you can appreciate hyperdynamic LV, normal right ventricle. Again, focused on the aortic valve, calcified systolic, decreased excretion of the leaflets, severe aortic stenosis by looking at it. No much AI, minimal aortic regurgitation. Short axis, tri-leaflet aortic valve. The peak gradient that we got was, the velocity was 3.2, peak gradient 40, mean gradient 24.
Okay.
Next.
Anything else? Any special on that?
Yeah.
We cannot go forward.
Sorry. Yes, stuck here. So the aortic valve area by the continuity equation measure 0.8 centimeter square is a low flow aortic stenosis with a stroke volume index of 26 ml per centimeter square. Next. As you can see here, the distance, the stenosis is 3.7, 3.9, and the ascending aorta is 3.7. The arch measures 3.4. And I know that Dr. Sharma wants to talk about this new coupling between the right ventricle and the PA pressure. On this patient, the systolic PA pressure is 28. The TAPSI, which you would like to talk about, Dr. Sharma, is 2 centimeters, which is normal, and the ratio is 0.7, which is also normal. And we can talk about this on the discussion. Thank you very much.
Very good. So this is the one thing we'll talk about. Another parameter is coming on these patients in the particularly low risk, the RV and TAPSI relationship, which we'll talk a little more later. So go back to the slide presentation, please. Good. So this is our echo, which we already have done. Now the Sahil about the CT.
Yes, the CT scan shows a very good annulus and LVOT for a transcatheter transfemoral TAVR. Annulus area is around 498. The LVOT is around 426. There's not much annular LVOT calcium, so it's very good valve for 26 SAPIEN. Next slide. Very generous sinuses, more than 35. STJ is generous. Next slide, please. And good coronary clearance, good STJ height.
So this, we don't have to much worry about the coronaries. In this case, very high coronaries. Yeah.
Absolutely, but it's a very horizontal aorta, as you can see. With the very calcified and thickened valve.
Okay. Okay. So here, and this is what just came out. I would say surprised because patient did not know, and we saw that Dr. Larakas just pointed out the dimensions at the level of the ascending aorta and up to part of the sinuses ascending. They are within normal limit kind, and we found this the fusiform abdominal aortic aneurysm, which was measured as 6.4. So, Remy, tell us what would you do in this kind of situation?
Sure. So when looking at the aneurysm, a few things are really important. One is the proximal neck below the renal arteries. The aorta there is measuring around 23 millimeters in diameter, and the length of the neck is over 15 millimeters, which is what you want for an infra-renal endovascular aneurysm repair. The iliacs are measuring around 16 millimeters, both common iliacs, roughly around the same. Both common iliacs are long. So the anatomy here is very favorable for an endovascular aneurysm repair. There's not much in terms of neck angulation. It's a long neck, good size, not much neck thrombus. And so for this patient, we went with a device with suprarenal fixation, a Medtronic endurance stent graft. We chose a 28 millimeter proximal stent and then 20 millimeter iliac limbs. And we found, at least here, since we're going to have large bore access, that it's safest just to do it in one treatment session rather than bring the patient back for a second large bore access.
So in this, you are going to go for both sides?
Yes.
Yeah.
So we have a 12 French sheath on the left, and we have the Edwards sheath on the right. And then we will use the Edwards sheath as long as the seal is intact to deliver the stent graft, which is 16 French.
Okay. And what is the concern or relationship with this AAA in terms of the renal artery origin?
So in this patient, not much. The neck is long. We have at least 15, if not more, millimeters from the renal down to the origin of the aneurysm. And so in this specific case, not much of a concern. Certainly, when you have a shorter neck, there are adjunctive maneuvers that you can use, endo anchors, fenestrations, and many other advanced endovascular techniques that can be implemented when there's not enough proximal neck.
So basically, if it goes a little up, you will cover the renal arteries, but you do some kind of fenestration to retrieve the renal arteries.
Correct. Exactly right.
Okay. Beautiful. Good. So this, Sahil, anything new about this aortic arch?
So it's a type 3 arch, as you can see, very tortuous innominate. So these are pretty tough to cannulate, especially both the vessels for sentinel, but we try to do sentinel in calcified valves. So we'll try, if we cannot get both the filters, we'll at least try for one filter.
Okay. Go. So sum it up. This is the 79-year-old patient with severe AS and infra-renal AAA. Otherwise, risk mortality point of view is 2.4, and evaluated by all the team members, and particularly patient has the radiation before, felt the appropriate case for TAVR combined with the EVAR, and that actually is better. Question is, there are some data, some people, I don't know much about the literature on that issue, that if you do your TAVR, there are some, and patient has a large aortic aneurysm, is there a chance for rupture?
So our experience is minimal. Of course, these happen at the same time rarely. We have one case here where we did a TAVR in a patient with an abdominal aneurysm that did rupture after the TAVR. You can imagine that the amount of pressure in the infra-renal aorta and the hemodynamics could potentially alter the behavior of the aneurysm. And there's no way to really predict that. It's such a small sample. There's no way to predict when that will happen.
So good. So I mean, if anatomy and creatinine and everything else is suitable, you'll like to do both at the same sitting.
Correct. I think that in this kind of case where it's a relatively straightforward anatomy, where you're treating it with a simple infra-renal graft, and it can be done within 20-30 minutes after the TAVR, I think it's a reasonable thing to do, and we can do these procedures with minimal contrast and quickly once the large bore axis is obtained.
Beautiful. Good. So now, what we are going to do is another thing, that is the SAPIEN 3 Ultra RESILIA, the new valve, which has a better durability, and I'll go through that in my theoretical discussion a little later, and they're trying to do a sentinel. So I'll ask now Anu about RESILIA. So this is a new addition to SAPIEN, the valve which is a more durable. Which patient we should be using it? RESILIA is the new valve which could decrease the calcification. Basically, it has a lot of data on the surgical side, 5-7 year data in the selected series, and now we come to the TAVR arena first time because it's a proprietary technology of the Edwards, and that is associated with the lower leaflet calcification. So question comes down to, of course, anything comes with some price. Because of the proprietary technology, it's a little more expensive than regular TAVR valve. I'm just asking this question to Anu, that which case we should be doing this RESILIA, and we decided in this case RESILIA for what purpose?
I think until we have more data, so far we're using patients with low risk, younger age patients, and we have started doing it for the last few weeks. So let's see how it goes.
Okay. And Sahil, our selection for RESILIA was because?
Yes, so patients who have longer lifespan and expected life expectancy more than 8 to 10 years are otherwise low risk. We've decided to use the RESILIA valve. Again, this, you could have a 65-year-old patient who is otherwise prohibitive or high risk and life expectancy not more than 5 years, then I think a normal SAPIEN valve should do the trick.
Okay. So now we'll ask this very important question to our surgical colleague, Dr. Phil Sufi. So what has been the experience of the RESILIA aortic valve? Edwards make that this valve has been there for 5-7 years and there is no degeneration.
Right.
You have
as you
comment
know,
on it?
one of the issue with tissue valves is calcification that can happen at any age, and a variety of technology has been used for calcium mitigation. And until recently, until a decade ago, glutealdehyde preserved valves were the most commonly used technology for tissue valves. Now, Edwards came with this new technology for calcium mitigation. And the studies that used in surgical arena was the Concurrent trial, and at 5 years, the structural valve deterioration was about 0%. There was no class 2 or 3 structural valve deterioration in surgical patients. So therefore, the only valves available from Edwards tissue valves are RESILIA, and the glutealdehyde preserved valves are almost no longer available. So I think it will happen soon in your area and our area of endovascular approaches, and all the SAPIEN valve will be with this technology RESILIA.
Beautiful. So I mean, in one day, if there's no harm, it's not a thickened valve. Now there is some data that it leaves some gradient. Is this, there are, again, it's very early, and I think the data need to come some more. People believe maybe gradient usually is like 3 to 5, maybe 8 or 10 with this valve. So I think you just need to see. Our experience has been fine. We actually had a no gradient, means no gradient basically means once we call a zero gradient, usually echocardiographic will be about 5 to 10. There's always a difference when hemodynamics is 0, and many studies have shown that. It's further. So with that note,
also other thing we have noticed is inflation is not as easy as the regular SAPIEN stiffer valve.
Okay.
And I think the couple of cases we have done, we have seen a few millimeters extra gradient.
Yeah. Okay. So good. So just we need to see now. If we can come back to our Pedro, our presentation is done. Now we are ready to cross the this valve with the using the AR tool,
Show me the aortogram.
right?
Yeah.
It's AR two, and
We need AL1, right?
and it's not a dilated aorta, so you
No.
need to be then. So this is the
It's very horizontal.
aortogram.
You can
Yeah.
see. Yeah. Want to use L1? And this is fused, okay?
This is fused at the other
that's
side.
The trouble. Yeah.
Okay.
Get us
So-
AL1 maybe.
Or AL1, look into the AL1 also, because anytime you get more than 3.2 centimeter root, probably AR2 is not enough. You go to AL1 or AL2. Pedro, any question from your side?
I think it's going very straightforward. It's a
Yeah.
beautiful illustration of the two pathologies. And
Very nice.
yes, important to mention to do the
Very
EVAR
horizontal, you see.
after the TAVR. We, for Dr. Tadros, we did one thoracic in which the EVAR was done previously to the TAVR. So what is the rationale, of course, clinically or to do it in this order?
No, what we were told that if you're going through your sheath is going to go through the aneurysm, you do it after you do the TAVR. If it is is above in the thoracic, then okay, you fix the TAVR first, because then you don't worry about the sheath, and then do the graft first, and then EVAR, then you do the TAVR. So this case now they have crossed it and going with a long
Fluoro?
wire and ready for pigtail. Okay, what is the strategy now? Balloon dilatation or direct?
Yes, very calcified valve, so we should do balloon dilatation. 22.
Okay. So usually we go to the minimum, the aortic, the sinus of valsalva, or sorry, minimum diameter of the aortic annulus, which in this particular case was
All.
Around 20. Fluoro?
it was just 24.
Yeah.
So 22 is good.
Okay, ready? Hold it.
And don't go beyond that, because then you have risking the aortic rupture and so. But you saw that very heavy calcification of the leaflets. And try here is that trying to bring the pigtail to the apex, and now ready to use with what
Let's
wire
see.
we are changing?
It's a Safari wire.
Safari. Okay.
Now to show the gradient, 1 second.
Yeah. Okay, we saw the gradient. Yeah, hemodynamics, they are saying it. Yeah. Good.
Dr. Kinney, what are some of the challenges with the horizontal aorta?
See, you have to, once we are placing the valve, I think you have to be fully flexed to get into. And once you're there, and I think we can unflex it and then see. Now, as you're inflating, you have to be very careful. Though we think it will be 10%, we could be 0 or even minus going to the left side, left sinus.
Okay. And what about the sentinel? I see the sentinel in the
hanging.
Yes, so
ascending
once-
aorta.
So we could only get into
Descending.
the subclavian.
Okay.
It was predicted because extreme tortuosity in the subclavian there.
Okay.
I think aortic manipulation itself has a lot of risk, and something we don't discuss much, especially with a negative protected TAVR trial. Go ahead.
Pull the
So I
bar
think
back.
it's just safer to do
Where is
one filter, at least some protection from disabling stroke.
And Pedro, many other devices are coming. We are part of, we have been asked to join 2 of the trials where they're basically covering all the 4
150.
great vessels. Yeah,
Sine?
the coverage, one from the left radial, one from the left groin. So coverage of all the great vessels, all 3 great vessels. So we have not decided which one do we go. But I think still this field, in my opinion, the PROTECT trial, in my opinion, is not the end of the cerebral embolic protection device saga. I think it's a lot more to, and it's basically, just happened that everybody got so good at doing this valve. The prediction, which was about 3%, became 2.2%, so much lower stroke rate. So that's why you need a larger number, and hopefully that BCIS British study will answer that question, because they have 3 times more enrolled cases, 6,000 versus 2,000 we had.
Correct.
Okay.
Yeah.
You're going up.
Okay, now we are
Scottish-
ready.
yeah,
Balloon was
Scottish
done,
ventricle.
and it's a
going-
26 millimeter.
26.
26, nominal.
Little LAO, please.
Go to the
Yep.
position, right?
So LAO 13
advanced.
correlate.
Hold
Yeah,
the
I
wire.
think the
Where?
comment of
Yeah.
Dr. Sharma regarding the stroke is a very valid one. And for the audience, if you can make your institution a center of excellence regarding stroke, is an important move, because this is definitely a coadjuvant effort between neurology and cardiology. So again, try to make your institution a center of excellence if possible. Yeah.
Okay, so we are fully flexed. You see there? Get into, yeah, that's good. Unflex a little bit.
Perfect.
We're going to expose the balloon. Okay.
You
Okay.
can see that how the valve is lining
Yeah.
up.
Okay, show some dye. Mm,
It's actually very good there. So
yeah,
pull back,
leave
pull
it
back
there.
counter.
Pull back, same. Pigtail pull back all the way. Yeah, wrapped around, good.
No, it's wrapping around the,
Mm.
No, you need the wire. So all these catheters become a little softer. So there are some little stiff catheters are available now. Some, I was told that Cordis is making them so that they don't lose the curve, particularly pigtail. It's very common that once we advance, that catheter is there for half hour or so, become very soft. So we have to use the wire to move it. And then there is a space limitation always there.
give me the
You have
wire,
the sheath
give me
of
the
the
wire quickly.
valve, and so always need another wire in it.
Counter it so it can go to the, no.
It's, I think, wrapped around your commando delivery sheath. Yeah, good.
Okay, there.
Good.
No, you're
Now
good.
in there. Okay. Need to little advance.
1 second, 1 second. Okay,
You need to advance first.
Advance
before you
now.
Don't get die.
Good.
Yeah.
Yeah, that's good.
okay, 180.
That's good.
Pull back, we're too deep.
No.
Good.
Good.
Off.
Off. I think pull
Yeah.
back a little bit,
No,
right?
it's good. It's good.
Looks good.
Anu, can you
good,
explain the positioning of the valve?
Yeah, so here, you see that?
Mag in one.
We are about not
Center.
half and half, we are 40.
Yeah, 1
Show me.
second. Let's
Go
play
minus.
this one.
Yeah.
Yeah, right here. Yeah. Because you
About
just want
40% below.
Yeah. 30 or
It's
40,
a little-
because
30.
when
That's all you
each
need.
valve
Yeah.
shorten about 18% and
yeah.
more so from the top. So you want to just keep it very little there.
We
So
did
what was
pull
the
back a little
question
bit.
Sahil was asking earlier is when you have this horizontal aorta, you see that when we are expanding the valve right now, we want to make sure that it will be 0 when you reach the left side. Okay. So we're a little lower than usual.
Good.
Good. Okay.
Test once more.
Testing once more. Good.
Yeah, much
Okay.
better.
180.
But just to remember that more foreshortening happens from the top than the bottom. That's the key.
Okay. Going up.
Yeah.
Okay. Not easy. Every valve feels like a 29. Continue, continue, continue. Okay.
Off.
Okay.
Take some
Now,
parallax off.
this is the important point for the hemodynamics that
Yeah,
patient
we'll do that.
responded back. Many times they become heart block transient, pacemaker we continue. So this patient was pacemaker was there, but now there's no need. You're seeing
Okay,
the tracings
parallax
there.
is off.
Use the wire again.
Give me the
You
wire
can-
again.
You can remove the
Wire.
valve further down, then you can advance. See this now. Pull the wire.
No, that's
No,
nothing
pull
to do
a
with
little
that.
bit down. So it is.
Wire.
So this is the moment now that we are just going to ask our echo colleague to do it, echo, but we always want to do one. If there's no limitation from the creatinine point of view, we always want to do a little aortogram, although it's not
Putting the wire
necessary.
down. I think it's coiling in the
In the
the
aneurysm.
AAA, the aneurysm. Yeah.
Took the images.
Yeah, catheter may be having a trouble because of the AAA. Good.
Yeah, much better. Yeah.
Okay. So we are just no, but before you do, you want to do the pressure measurements?
No, not yet. We have to remove the.
Okay. No,
Okay,
I want
ready?
to LV, yeah.
Gently pull the wire.
Do that, yeah.
Nice.
Very nice.
Beautiful, good.
Very nice. So
Put a
See,
picture catheter
Farzan, we
there.
are barely zero on the left side. Yeah,
So-
just reached it.
that's the important point about deployment. You saw how it rode up on
Yes.
the left
Let
side,
me ask you a question,
especially in
then
these
we'll go.
This can
horizontal
come
routes.
out, right?
Yeah.
So we change to pigtail, get a gradient. Okay, come down.
So we are just going to check the gradient. And so now question is, let's ask Farzan on this. We haven't had in a long time. I mean, again, things could happen anytime. The aortic rupture, root rupture or so, and or lacerations. So how would we deal with that? What has been your experience? I know we have a couple of cases here, but from your surgical colleagues, the aortic root rupture and so, how do they respond?
Yes, I mean, there are several types of
You want
problems
to
that can happen. One, the easiest one is a aortic hematoma, that you may have a pericardial effusion that will be drained, and that would be the end of it. If you go toward
It's very
the
good.
rupture with expanding pericardial effusion, usually there is hemodynamic compromise.
stamp.
The patient may be at risk of cardiac arrest. Therefore, they need
Looks
an
good.
emergent
sure.
institution of cardiopulmonary bypass. We have very quickly clamp the aorta, protect the heart, and open the aorta. And often, again, if the laceration is small, you can get the valve out and do a local repair. If this is not the case, then you have to do a root replacement using what we call a Benthal procedure with the biological valve. But again, in our institution, which is a center of excellence, this incidence has been low, and I don't think we have had to deal with this problem during the last 2-3 years.
Yep.
It has happened in a few number of cases years ago. And again, it's emergent surgery, cardiopulmonary bypass, remove the valve, and either do a local repair, but
Zero.
if the lesion is
Zero everything.
expensive, then we have to do a root replacement.
Okay, now to just comment on, and then we'll let you go on your case because we are done here. So what about your experience on the TAVR explant? Every surgeon says that it's a very difficult situation.
So I have done a few of these cases.
again,
Again, the experience remained very
Flush again
limited.
with gradient.
If
Some
the
gradient.
valve that
What
is
is the
used is a SAPIEN valve,
Before the flavor.
it's easier because this valve has a lower profile compared to the Evolute valve,
If you get
and usually
measure
sits
the-
inside the native valve. So you can remove the native valve with the SAPIEN valve sitting inside. Whereas with the Evolute valve, the valve is has a higher profile. Sometimes it's anchored to the aorta, or sometimes it goes deep into the aortomitral curtain, and the removal
Okay, zero again.
of the valve
Beautiful.
can add to
Zero
the
again.
risk of the complication,
Okay,
with the
that's
risk
good.
of
That's good.
local injury to the ascending aorta or to the aortomitral curtain.
Yeah.
So, but it can be dealt with it.
Yes, clearly the TAVR explant is a totally new disease process, and which everybody is learning. The initial data have been a high mortality up to
Yes.
13-14%, but I'm sure with experience those numbers will go down. Some center claims it in the single digit 2-3-4%, and our also just a very small. We haven't had any issues. So you
You
saw
want
the
to see
hemodynamics.
echo live? Yeah, you see the hemos there.
There's no gradient.
No gradient.
5.
Yeah, and remember when we have the no
3,
hemodynamic gradient, echo gradient will be about 8.
Yeah.
What is it now?
It's 5 peak, 3 min.
Good. Wow.
Nothing, no AI, no PVL, nothing.
Beautiful. Good. So let's pull back the pigtail now from the LV.
Give me a wire.
And then we hand over the
use the wire.
reins to now
Very tortuous.
Dr. Remy Tadros and the team, which are trying to work on. And he'll have this mic He will be mic'd so that he can also show, because we have all the cameras, ceiling cameras, side cameras, and we really thank Dr. Phil Suvi to be the part of it. And now the second part will start now.
Which wire do you have in there, Sam? Which wire is that?
That's the supercore.
Okay.
Let me do it. Yeah.
Do you want some more light, or we are okay?
Want to leave it until the end? Or you want to take
I'll
it?
be with you.
Leave it?
Okay, while they're trying to get set up, Pedro, we can go with some slide presentation, because this now going to take the half sentinel out. So it clearly that some the coverage is better. So what we are going to do is some recent publications in the TAVR field. One is the new TAVR valves, then post-TAVR gradient and 2-year mortality, then prognostic impact of cardiac damage after TAVR, the impact of RVPA coupling on TAVR outcomes, and lastly, safety of the
John,
balloon
bring up
valve
the,
fracture
stent
in valve-in-valve TAVR.
This is the
So
stent
this is
right?
we do. So these are the figures. Many of them are yes, many of them gone, continue, but a lot of them have a very promise, like the Navitor just approved by FDA, Accurate Neo 2, my valve, actually my valve is the one which I did the first one in India 4 or 5 years ago. Another self-expanding is the Hydra valve. Then Gina valve particularly has those clips for aortic regurgitation, and the many are shown there. So key is the important issue about the valve calcification, and why the valve degenerate is because of calcification. So bovine pericardial tissue to reduce calcification, Resilia tissue has the potential to extend valve longevity and reduce reintervention. Then how it is? Is the proprietary tissue technology, stable capping, as Dr. Phil Sufi earlier mentioned, that not a glutaraldehyde. There's a separate, blocks the calcium, stable capping, binding sites within the tissue, and another dry tissue storage. And the Resilia tissue technology blocks the receptor that enable calcium to bind to the tissue. So this is where SAPIEN 3 Ultra now becomes SAPIEN 3 Ultra Resilia
expands,
valve.
right?
So clearly, very promising. Is it promising? Well, let's look at the data. So we have the data of the Resilia tissue valve. See the calcium deposition less on the left side, and same thing, we saw 72% lower calcium content. And this actually leads to, which was said earlier, commence aortic trial of 5 years, 0 structural deterioration. So that's good. But we want to get to the
Think about that positioning. Crossed, right?
TAVR valve, and this is where now Resilia is available on all the sizes, and it will be a good thing for us to have. So this is very important. Then there is the Evolute FX TAVR system, which is those points in the lower part, which we have shown before. Evolute FX, we were the first one to implant here in New York. And better delivery system, radiopaque markers provide a reference for deployment depth and commission location and ease of use. And these are in the Evolute family. Then on the Portico side, from Abbott, this was the earlier generation Portico, and now the next generation TAVI valve is the Navitor. Navitor, basically, as you can see, the height of the leaflet has decreased, and more important, there is a cuff to have a better sealing, less paravalvular regurgitation. The data have shown very nice in terms of lower gradient and very good success of the Navitor TAVI system. Then the Accurate Neo 2, which a lot of data have come out about this. The Accurate Neo has its own problem, but then added the crown height and the added skirt, outer skirt has really decreased the paravalvular leak. With the still undergoing trial at present, because of they needed to do all kind of cases, and now they're left with the low risk cases only. We are part of the Accurate Neo 2 trial, and this is still probably will complete in next 1 month or 2 months, and we expect data will be available by end of this year or early next year, and this valve will be with us probably mid next year. So difference in the old Accurate Neo and the Accurate Neo 2, which is the better, you can see the PVL has gone down to moderate 3.5 and severe is almost 0. So 3-fold lower frequency of moderate or greater paravalvular aortic regurgitation with Accurate Neo 2 overall seems to be a better valve. This is from Ital Neo registry. Then the Hydra CE valve, lot of work done by Lord Sundergaard and the team in India being used. And this is actually, they presented the data on the first experience using this Hydra valve. This is a self-expanding valve. And 30-year death 7, 1-year death of 14.6, and the residual gradient 8, and new permanent pacemaker about 12%. Moderate to paravalvular leak in about 6%. So I think 6% is a little high, but good valve orifice. Data are that any self-expanding valve gives little higher aortic orifice compared to balloon expandable valve. But I think the 1-year death, but though that included high-risk patients also, so 14.6% is reasonable. So it is available as a CE mark in Europe, and so of course available in India. And I used it about a few months ago on one case. So it's good. Then this is my valve. Actually, I was the first 5 I implanted at ESCC in Jaipur. And now after the 100 cases done, the approval by Indian government, the big advantage it is, the cost is 60%. The US valve, if you compare it to, it's like $30,000, which is about the same way. This valve cost about $14,000. So much cost effective, and at present has being used almost 100 cases per month. And other US valves, both the Evolute and Sapien makes another 100. So this really has increased the TAVR usage in India to about 200 cases per month compared to 8,000 being done here. So now there are a few points I quickly go while we are getting ready, and Remy, you tell us when you want to show something, we'll come to you.
So we can show it now.
Okay, so I'll stop here 1 second. Yes.
So if you look at the screen here, play that. Next image.
What is happening?
The next one. So here you can see the renal artery, and we've marked the renal artery, and we're positioning our graph. You can see the markers. There's a bit of parallax. We try to get our parallax out, and currently we're at cranial 36. On the center line, and using our 3D software, we would have to go to about a cranial of 50 to really get the parallax completely out. But this is pretty close. If I'm ever in a situation where I can't get the parallax completely out, I try to split the difference between the markers. So in this, that's what we've done in this case here. So now that we're in position, the markers are not completely. We can try to get a little bit better with the parallax here. Let's try that. Okay, we've got a little bit of coverage. I'll probably bring the device down just a touch. Pause that. Okay. What do you guys think about that?
Watch the Edwards sheet. Edwards sheet.
Mm-hmm. So we're going to deploy down to the gate now. Gate positioning is extremely important here. You can see how we want to cross the gate to try to make it easier to cannulate. We just popped the gate. You can see that there. Now, before I release the top, I'm going to confirm that we're happy with our renal artery there. Perfect.
Perfect.
So now that I'm happy with that, I'm going to pull our pigtail down. I'm going to release the top of the device. Nice and slow as to not shift the graft. Good. All right, so now we got to cannulate the contralateral gate. So I'm actually going to bring this sheath down. Give that floppy glide wire.
Floppy glide. floppy glide wire.
So now we need to cannulate the gate. Okay, John, hold that other sheet for me too. And then you have that Berenstein or the glide catheter.
Glide catheter. 4 French is okay.
So I'm going to make an initial attempt with this here just by straightening it out. We have our 12 French sheath on the opposite side already.
Yep. Oh, missed it.
We have a torque.
You want to use a glide, it'll be better.
Yeah.
A glide cath.
Swap that out. We're really close. So by looking at the gate in multiple gantry angles, you can actually get a good sense of where the gate is in terms of cannulation. Okay. Let's get the pigtail again. So now it looks like we've cannulated the gate. Let's change this out. Again, using different gantry angles to make sure that you're lined up is important. So now once we're actually in the gate, we'll bring our marker pigtail, please. We like to ensure that we're actually 100% in. So now that we're in the gate, we're going to put our pigtail and we're going to spin the pigtail inside the body of the stent graft to make sure that we're not behind the stent graft. You can see the gate moving, which is a good sign. And we're actually going to spin this inside the neck.
Sign, yeah.
You can see the gate moving, which is also very favorable. I'm going to rewire. So that looks like we're in. Now we want to get a stiff wire.
Amplats, please. Amplats.
So now you have put your pigtail above the graft.
Okay, so now we're going to put a stiff wire. This is an Amplats wire. You have that sheath? I'll leave this then. Now we're going to go the opposite oblique. Yeah. To see the hypogastric origin. Okay.
Want some
A little
contrast?
yeah, a little contrast.
Won't be able to. Give me some contrast, please.
Just about. Just putting a second limb.
Pause that. Let's go ahead and count.
1 second.
Go ahead. What, do you want to go 124? 124 is fine. Right? We can be a little short. Yeah. Yeah, perfect. So let's get the 124. So we're going to go with a 20 limb to seal in that slightly larger portion above the hypogastric. All right, let's get this thing out. Hey, John, get the limb. Well, it won't go through this 12, right? Okay.
And then you're going to right side both?
Then the right side after this.
Okay.
Should be done.
But
in,
right side is a single.
Yeah.
Yeah.
So while you're putting the both,
can
let
finish
me
your
go for a
talk.
few minutes. Yeah.
Yeah.
Okay, let's go back to the presentation. So one as you saw, the very precisely to be in the lumen, they went with the marker pigtail above and then pull back to so. So just to few things quickly I go. One is the transvalvular pressure gradient and
have the
all-cause
dilator.
mortality following
The
TAVR.
dilator from
And this is the data basically.
12 dilator.
So what you see on the left side is echocardiographic, right side the invasive. Remember echocardiographic 15, invasive was 0.
Once this
But
is
more
deployed,
importantly,
backfill it.
you see
Yes.
the residual gradient which is on the horizontal axis. In echocardiogram, there is a lot of variation. There's not a linear relationship. Post-TAVR, invasive hemodynamics like 10 is the cutoff kind, and then higher the gradient, then higher becomes the hazard ratio for mortality. So Dr. Larakas, we asked him, tell us little this discordance on the echo and invasive. We see it very often, and papers after paper are talking about it. What is the exact mechanism of it? That usually invasive we say 0, and it's a 5-8 in the echo.
Don't move, don't move.
Yeah. I mean, usually can be many things. You know, the most common thing is that sometimes the ventricle is
pressure
empty, so you have like some SAM that is causing higher velocity, and that's most of the time that's the problem, that you have high gradient through the LVOT because of small ventricle, or SAM, or hypovolemia, or the patient is tachycardic. So all this stuff it causes this higher
14,
gradient than what
24,
you see with the pigtail hemodynamics.
Consistent, great. So basically, the conclusion was that the large retrospective analysis, the impact of transaortic gradients on mortality after TAVR was not linear and complex, showing opposite results among echocardiographic and invasive measurements in low gradient patients, which we talked about. Then second, cardiac damage. This is the big thing which is coming up now. The cardiac damage after aortic valve replacement. Remember what has happened. You do a good valve, but patients still die, have follow-up, not from the valve related, but because of the structural degeneration which has happened to the myocardium and the valve leaflets, other valve leaflets. So the question is that in the cycle, if you stage them, and these are the data from the partner 2 and 3 trials, so intermediate and low risk, the AS staging based on the extent of cardiac damage. Stage 0, no cardiac damage. 1, 2, 3, 4. LV damage, LV and mitral damage, LA, pulmonary vasculature, and RV damage. So those are the echocardiographic findings, and shown that increased LV mass index, LA volume, system, pulmonary hypertension, and moderate to severe right ventricular dysfunction. So, Stem, do we worry about when we are doing this kind of a baseline in terms of echo? I know all the data are presented, but we don't classify at present pre-TAVR echo based on these staging classification. Should we start doing it?
I mean, that's a good idea to start doing, but basically we already do all these things. You know, we measure the pressures, we measure the diastolic function, the E to E prime. So all these are done. Of the ventricle we can do by strain, and there's a lot of data on that.
Yep.
Of course, with MRI is the best, but we cannot do MRI on everybody. But I mean, basically, we don't say stage 1, stage 2, but all the data is available to classify them on stages.
Right. Individual data are definitely presented, and LV strain, which I have shown it last year,
Let's hold it.
is a very important predictor. So that is more commonly presented. So what they found is
Contrast.
that is inoperable,
Yeah.
intermediate, and low risk.
right?
They have a TAVR vent in 60%, and surgical valve was in 40%. Why it was important? Because they have paired echo. Look at this. The almost 50% of patients are stage 2. There's some cardiac damage has occurred.
Yeah.
Before we do at the time of the aortic valve replacement, whether it be a TAVR or SAVR. Very important. Why it is important? Look at this one. That basically, once you do replace the valve, you either improve, no change, or worsen. So no change almost in 50+%, improvement in 15, and worsening about 26.5. You say, why it is important? Look at the hazard ratio on the right side. For 2-year clinical outcome of the death on the top, death and heart failure hospitalization. If you worsen, almost twice the risk of death and heart failure of hospitalization, and your improvement, you do a little better. Not a great statistically, but you do definitely do better once you improve. So clearly that things can, and also they found the predictor of 1-year worsening in the cardiac damage is hypertension and surgical EVAR. In this study, the surgical EVAR had a higher cardiac damage, maybe related to some surgical procedures and so. And they also showed, as you can see, the Kansas City quality of life score clearly with the stage goes up. Higher the number, better it is. Lower the number, worse it is. The higher the stage, your quality of life score goes down. And just to say, once you replace the valve, by and large, your stage gets better. But we saw, or may remain unchanged, but clearly the key remains is that many of them, some even deteriorate. So clearly the baseline cardiac damage associated with the death, see the increasing death, 2.5, 4.5, 10.5, 19, and 21. So baseline cardiac stage is associated with a higher death rate, same as the Kansas City quality of life. These put together, quality of life and death, increasing stages, higher those cardiac damage markers are. So basically what the authors concluded, then this patient undergoing EVAR, which is both surgery or TAVR, extent of extravalvular cardiac damage at baseline and its change at 1 year have important prognostic implication. These findings suggest that earlier detection of AS and intervention before development of irreversible cardiac damage may improve global cardiac function and prognosis, and that has been shown by 2 surgical trials of asymptomatic aortic stenosis. Now people are going down. Even in the moderate AS, it's not only just has to be ejection fraction, but if your the BNP is high, so any marker of the cardiac damage, which is we are part of the trial, TAVR trial, that we need to go early. And that is where the whole field is going, that go early in the disease process. Don't let the disease occur. Once in the risk factor patient, you go early. Then the right ventricular pulmonary artery coupling, which you have briefly spoken on this particular case. And basically what they showed, if you have RVPA uncoupling, or you have RVPA coupling, which occurs in 40 and 60% respectively. And it looks like that if you have coupling, it is good.
Yeah.
And you're uncoupling, your risk of mortality, stroke, or hospitalization is higher, particularly mortality and rehospitalization outcome at 2 years on the shown. So tell us a little more, to teach us, STEM, that why this uncoupling is bad. What does it mean?
So basically, RV to pulmonary artery coupling, to make it simple, means how good is your right ventricle. So, and you measure that with TAPSE. TAPSE is one of the ways to measure how good is your RV. And basically what you measure is how, basically TAPSE means tricuspid annular plane systolic excretion. How, with M mode, how your base of the free RV wall moves, and normally it's like 2 to 2.5 centimeters, 20 to 25 millimeters for the TAPSE to PA pressure, and basically it tells you how good is your right ventricle for that pulmonary PA pressure. And usually the normal is above 0.7. On this particular patient was actually 0.71, so that's normal. On this particular study that Dr. Sharma is showing, the number was 0.55. And if it was less than 0.55, what that means that your RV is bad for the PA pressure that you have. And that makes sense that if you you have high PA pressures, your right ventricle is failing. So of course you have bad outcomes, as these patients, most of them had. So basically, to make it easy, it sounds a little bit sexy, but it's very easy to understand, and it has a lot of flaws. I don't think you can apply this because it's a lot of technicalities. Also, if you have severe TR, the PA pressure is not accurate, so it has a lot of flaws, but it's a quick way to give an estimate of what will happen to the patient based on the PA pressures and the right ventricle.
Absolutely, and part of that is incorporated in the staging of the aortic stenosis,
Yes,
which I
yes.
showed. All right, Remy, you are ready for part 2?
Yes. So we're
Okay,
displaying the-
let's come. No, but they're live, they're showing live there to show.
Yeah.
Yeah, let's go, come
back
back
tension.
again, yeah.
So right now we finished the left limb. We're deploying the right iliac limb. That's good. Don't come back any further. And then the stenting component's going to be complete actually. And then we got to balloon the seal zones and then do an angiogram to confirm that the aneurysm is sealed. But that's essentially it. As you can see, it didn't add a whole lot of time on the back end of this complex case.
No, but things are going very fast.
Very good. Good. Hold the sheath above me. We have the Reliant balloon ready, and we're going to balloon with a compliant balloon, a Reliant in this situation.
Mhm.
And you can see we're actually working through the Edwards sheath the whole time.
Can you just do the dry cine so that people can see
Yeah.
that you've connected both the trouser, pants, and everything else? Both sides. Huh? Yeah. Yeah, right there.
Yep. Right.
Yep. Beautiful. So just by this fluoro, looks good, right? From your point of view?
It looks very good.
Very good. Okay, now you're doing some balloon dilatation. We come back to our presentation again. So we all combine, type up that he probably will, Remy Tardos needs 5 minutes and I need 5 minutes and we'll complete it. Now, one of the important issue remains the bio-prosthetic valve fracture. And what happened when you do a valve tower, valve-in-valve tower? Clearly, we know the pre-existing pacemaker, the permanent patient prosthetic mismatch is associated with a bad outcome, and therefore a small surgical valve versus large surgical valves always had trouble. And the key is, this is the largest study, largest, we have some data on the bioprosthetic valve fracture, but this is the one of the best one, large number, 600 plus, compare against where there was no BVF. Bioprosthetic valve fracture was not done in 79%, and within there, when it was done, whether it was done pre-implant TAVR or post-implant TAVR, 1/4 done pre, majority done post, and this is where we show the overall difference, and these were not different basically, but this is the real meat of the case. That is in-hospital safety outcome, BVF and no BVF. Look at this one, favors no BVF. We do balloon valve, the bioprosthetic valve fracture, but the data in the largest trial so far on this field does not support the doing the valve fracture. Higher cardiac death mortality, combined life-threatening bleeding, all significantly higher with the so therefore favors BVF versus none favor BVF. Pacemaker, although are not significant, and echocardiogram, only thing is that by doing the BVF, you get a better valve area and lower gradient. That's it. You improve the from 1.4 to 1.6 centimeter square. Gradient from 22 went down to 18. But other things, in-hospital mortality is much higher, and these are now other safety outcomes. Now question comes, do you do before or you do past? Now look at that one. Pre-implant BVF had a higher trouble compared to post. So therefore, anytime we need to do, that should be done post rather than pre, based on the data from this registry, as you can see here. And these are the other important points and show done here. And the same post-implant versus pre-implant, overall valve area, I told you that improves. So what was the conclusion? And I had to just go through this step by step, that BVF was associated with Early hazard of in-hospital mortality. Risk of mortality appears higher when BVF is performed prior to valve-in-valve TAVR. Modest difference in echo gradient aortic valve area, which is better with the BVF. Long-term risk benefit need to be further characterized, and we need to come up which case we should have indication, technique, and post-procedure management. So let's come to our take-home message. The newer valve designs are coming to the market for clinical use and focusing on lower sheath profile, flexibility of the delivery system, and reducing PVL. To enhance the long-term durability of the TAVR valve, proprietary technology of reducing leaflet calcification has now been incorporated in the TAVR valve system, and it is encouraging, especially in younger patients, as regard to the TAVR valve durability, which is RESILIA. Second, post-TAVR gradient of more than 10 associated with a higher long-term outcome, so make sure we do it better, optimize it, dilate it, whatever need to be done. Stage of the cardiac damage post-EVAR, which is aortic, surgical, or TAVR, is predictive of long-term mortality. In low-risk AS patients, hence valve replacement should be undertaken earlier in the life cycle of AS patients. The large registry data don't support the policy of BVF for valve-in-valve TAVR, and hence should be done judicially in selected cases, and if do it post-valve deployment. And lastly, the RV pulmonary artery coupling is another marker of long-term outcome post-TAVR. Questions quickly. The following are the newer TAVR valve except Evolute FX, SAPIEN RESILIA, Navitor, and Accurate Neo. And clearly, D is wrong. Accurate Neo 2 is the new, but otherwise Accurate Neo is the old. Navitor, SAPIEN RESILIA, Evolute FX are newer. Then following statement is false regarding the cardiac damage post-EVR, TAVR or SAVR, and prognosis. In majority, cardiac damage stage is unchanged. Cardiac damage deterioration associated with higher death and heart failure. Cardiac damage improvement is not associated with lower death, and cardiac damage stage is associated with KCC, quality of life status. And answer there is C. Cardiac damage improvement is not associated with a lower death. Then following statement is true about the BVF during TAVR. BVF is associated with higher mortality as versus no BVF. Pre-TAVR BVF was similar outcome as a post-TAVR BVF. BVF is associated with higher bleeding vascular complication, and BVF does not increase the stroke rate as no BVF. So answer is B. Pre-TAVR BVF has similar outcome? No. Pre-TAVR BVF has a worse outcome compared to post-TAVR BVF. With that note, we have completed our presentation today, and we can go to the live again with our colleagues.
Completion.
Go back on Flora now, good.
You can see the graft came down a little bit, and there's still an endo leak. So in this case, we're going to cuff up with an additional 28 cuff to hug that renal. I think with some anterior angulation, the graft came down a little bit. Not a big deal, but this is something we can easily manage here. Let's get the... You have a 28 cuff?
Yep. So tell us what you're going to do now.
So there's still a type 1 leak. And I saw when we deployed the graft, it did come down. It came down probably 5 millimeters. And there's some anterior angulation here. So what we're going to do is we're going to cuff up and reballoon that proximal seal. And I think that would take care of this problem here.
But this is still in that sac.
Correct.
Right?
So there's still flow in the sac. Correct.
Right.
So that's
the flow in the sac. Okay.
We call that a type 1A endo leak.
Endo leak. Okay. It is a covered stent.
So the sealing areas need to be ballooned a little bit, and it should.
We're going to put a cuff, yeah.
Yeah.
Okay.
Just little cuff.
Now, with that note, you saw I think we need to conclude, Pedro, our today's presentation with the combined. They just need to patch up a little bit, a little more cosmetic, make it perfect. That always has been the policy of every interventionalist, whether it's a surgical, coronary, structural, or vascular, or so. We want to make it perfect, so otherwise it looks quite good. And within 1 hour time frame, we were able to do. We had a little late start, but we finished in 1 hour time frame. So both TAVR and EVAR together. So you can conclude now.
They can continue recording, I think.
They can continue to record. They will continue to.
Product.
Yep, of course. But you can complete now, Pedro.
Balloon here? Or?
Absolutely. Well, thank you so much for the heart team for this super exciting case in we're combining the EVAR and the TAVR.
This over here.
And remember, everything is recorded and is available in our website at www.cclifecases.org. Thank you so much for your attention.